Good afternoon, World Health Summit. My name is Serah Makka. I'm the Africa Executive Director for the One Campaign, and I welcome you to this conversation. Today, we're talking about transforming the global health architecture, rethinking governance, and innovative models. So let's put plainly what's ahead of us. We have aid reducing, public debt reducing, the fiscal space is shrinking for many countries, and we have the needs increasing. So clearly, the math isn't working, except we change this equation. We also know that Africa will be the greatest part of the world with the youngest and most dynamic population by 2050. We also know that many African countries, about 50% rely significantly on donors for their health care. So today we'll have a concrete conversation about what can we do about this. We want to stress test some bold, domestically led pathways. And I want to emphasize that, domestically led pathways. Because we have to come up with a new global financial architecture. We're calling on our partners and our allies to help us think and transform how we think about health financing. And importantly, we have 4 levers we're putting on the table. How do we increase fairer, more transparent health taxes? What do we do about mobilizing diaspora capital into many African and low and middle income countries? We'll talk about making the health economy less of a cost driver and an expenditure and expense and more of a revenue source. And then we'll talk about health for debt swaps. So here for the next 90 minutes, we'll focus on specifics over slogans. We'll put trade-offs on the table. We'll have a real conversation. And we'll talk about actions. In the next 12 months, what can we execute for people and planet? We'll start with a short keynote to set the stage, and then we'll bring in the voices of government, multilateral organizations, CSOs, private sector, to talk about some fast, focused, fair interventions we can have. But before the keynote, let me introduce to you my panel. And panelists, as I call you, please come up on stage. We have Winnie Byanyima, Madam Winnie, who is Executive Director of UNAIDS, a global voice on equity, who will challenge us to innovate without leaving anyone behind. Please, round of applause for Winnie. Dr. Kaseya, the Director General for the Africa Center for Disease Control, he brings a regional game plan for countries under debt distress and how to ring-fence services, mobilize domestic resources, and scale efforts. We also have with us Dr. Thomas Schinecker, CEO Roche, and the President of the International Federation of the Pharmaceutical Manufacturers and Association. From the private sector vantage point, come on ahead, Dr. Thomas. Dr. Saia Ma'u Piukala, who's a regional director for WHO Western Pacific. He brings a powerful voice for smaller and vulnerable states, how to redesign reforms that mobilize new resources. Join us, Dr. Piukala. Last but certainly not the least, we have the Honorable Minister of Health, Dr. Mónica García, Minister of Health from Spain, a progressive donor government to bring the case for reliability, equity, and instruments like debt for health swaps. And you might ask, why this mix of participants? Well, it's clear that the architecture of health matters to all of us. What happens somewhere else affects all of us here. Diseases really know no boundaries. The rules, the incentives, and the financing models we choose today will affect who gets care tomorrow. So we just don't want to plug financial gaps. We want to redesign the systems around national leadership and shared responsibility. And you, our audience members, are not left behind. We ask that we will have a Q&A session as we proceed with the panel. If you have any questions, you'll have pieces of paper on your seats. There's some behind there. Please write them down. My colleague Hannah, please stand up. We'll collect them throughout the session and bring them up for conversation. And a quick note to everyone in the room, this will be live streamed. We will ensure that we have a productive conversation that's action-oriented. So we ask you to bring questions that make our ideas faster. Without further ado, ladies and gentlemen, join me to welcome our keynote speaker, Parliament State Secretary Dr. Barbel Kofler. She's here with the candid views from a major donor, Germany, BMZ, who will talk to us about grappling with fiscal pressure while staying reliable with the budgets that we have. Dr. Barbel, please join us.
Well, Excellencies, colleagues, distinguished guests, ladies and gentlemen, it's a great pleasure to be here with you, to hear after my short keynotes the discussion of distinguished guests and panelists. And of course, it's a really great pleasure to have you all here in this hall, all those people who are interested in global health architecture. Thank you that you are here. Thank you that you are coming. Welcome to Berlin. Well, it was said by our distinguished moderator, the times we are living in are challenging. We are at a critical moment for global health. Around the world, health budgets are shrinking. Debt is growing and international commitments are getting smaller. And the consequences are dramatic. Over 4.5 billion people cannot access the health services they need. Too many people cannot get vaccine, tests, or treatment, and simply because there are not enough supplies, not enough hospital beds, or not enough healthcare workers. One figure which is always really striking me and feeling devastated about it, every year, 4.5 million women and babies die from problems during pregnancy and birth. Those are deaths that could often have been prevented. And that's something we cannot accept. Something we as member states, but also as international community, private sector, civil society, that's a figure we cannot accept. Especially because we know that investing in health is not only the right thing to do, it's obvious, it's the right thing. I remember 4.5 million women and babies are dying. It's the right thing to do, but it's also a smart thing to do. Healthy people can invest more in their personal life, in the education of the future generation, but they also are driving economy. Investing in prevention and primary care cuts future costs and builds resilient communities. And if you don't believe me, there are enough studies at the moment available where it makes clear that every dollar we invest in, for example, in pandemic preparedness acts as safety net, preventing $2 to $10 future economic losses. So it's not only the right thing to do, it's the smart thing to do. And we, as Ministry of Economic Cooperation and Development, see three levers for addressing now this situation we are in, this decline in health spending we all face. Firstly, it was mentioned already, we have to come into a deeper conversation and into a deeper cooperation with partner countries to really come to a sustainable health financing by themselves in their countries. Reducing the dependence on external support is something which is key. Secondly, we have to broaden the donor base. That's not a contradiction, because there's still a time to go until it really works out for everybody on the ground. And thirdly, we have to have a close look on the health architecture so more can be delivered with the fewer amount of money we've got all in the budget. So a few thoughts to those 3 points. For the first level, the reduction of partner countries' dependence. I think we have seen very encouraging developments of leadership, for example, in August with President Mahama of Ghana, who hosted the African Health Sovereignty Summit and launched the Accra Reset in September. It aims to build country-owned systems to reduce reliance on external support. That shows quite clearly the countries we are all cooperating with, our partner countries, want to shape their own health agendas. And it's our common ground to strengthen resilience and build health systems that really are lasting and are sustainable financed. Well, to do this, there is also a big duty or a big work ahead of us, because we have to increase domestic resources for health and improve public financial management. This can be done, and we've shown also in our cooperation that countries are getting further if we cooperate on that topic. I've seen it myself in a country like, for example, Nepal, where with the support of our cooperation, the country itself began to set up a social health insurance system in 2017, which at least led to the situation that now, by March of this year, more than a third of all households are covered by health protection. There's a lot more to do, and nothing is perfect already on the ground, don't get me wrong. But it shows that there are examples working, and we can work together on those things. What the World Health Summit can do, or why it is so important for us, is because you are all here. We are all coming together and sharing the best practices, how we really explore innovative solutions together. The second lever, broadening the donor base. I was just pointing out, even if partner countries make good progress on increasing their own resources, there is a time period where external financing will continue to play an important role for many countries, even especially for those who have not so many financial means by themselves, for many countries for a long time to come, maybe. So it is essential that support is still here. And we also know that there are future health challenges which can only be solved if we're working together. The one thing is the financial need, but the other thing is that there are health situations which need multilateral cooperation. As we're always trying to explain, some people who won't believe it, a virus is not asking for a visa. So we really need to cooperate and work on a multilateral base. And I'm sure a lot of people in the room here are working for that organization also. A good example for that, I think, is the Global Fund to fight AIDS, tuberculosis, and malaria. The Global Fund is a multi-stakeholder partnership that involves public and private donors as well as civil society. It is the combination that guarantees its success. And I think we are all here also to tell stories which worked. In the last 2 decades, the Global Fund has saved 70 million lives and achieved widespread improvements in health systems and prevention. And that is why we need more donor countries, larger foundations, and also private companies to be part of an international health financing system. I am proud to say for my country that Germany will continue efforts to get them all aboard. Let me come to the third level I was talking before, and that's one of the big issues we all discuss here at the World Health Summit. Let me come to our global health architecture. Well, the global architecture has delivered impressive results, and I think it's always necessary that we underline that. The system has provided a lot of support. But we all know there are new challenges, and we have to adapt to those challenges. Sometimes the system is too complex. Maybe there are duplications we have to have a close look on. And often, and I have to admit that myself working in the BMZ, often we maybe have not listened too closely to our partner countries. Maybe some of our interventions were too much donor-oriented. So that's why I was pointing on the first level that we have to listen to our partner countries and listen to their ideas and be supportive there. So if we see those challenges we are all facing, I think in the city of Berlin, it's good to quote Albert Einstein. He once said, "In the middle of difficulty lies opportunity." And indeed, we have no chance but to see it this way. In the light of the major crisis we are facing, we need to make the global architecture fit for the future, and we have to do it now. Germany is actively advocating for a new agile architecture that prominently addresses health security and is able to respond quickly and effectively to new challenges, such as other pandemic, which might be just around the corner. As architecture that is based on an analysis, well, it's challenging in English, so non-English speakers try, on an analysis of future needs and how we can best address them in the most efficient way. That includes clear ownership and responsibilities, including on financing. We will need to determine, for instance, the areas where international financing is still required and where domestic resources can come into the play. And an architecture that enhances the efficiency and improves coordination among stakeholders. We know that many of the funds, for example, are already on that way and doing a lot. We've seen how Gavi, the Global Fund, GFF have already taken important concrete steps. Well, let me come to the end. Well, health, ladies and gentlemen, has been a key priority for Germany's international cooperation for many decades, across various governments and in the face of many challenges and crises. And that is why I'm really thankful to also one campaign for organizing this important session here. And please rest assured, despite increasingly tight budgets, and we have that challenge in Germany also, Germany will remain a reliable partner and advocate of using all three levels to address the global health crisis and to increase efficiencies. Because health should not be a question of where you come from or what you earn. It is a global public good that must be available to everybody. That's why we are fighting for it in solidarity together. Thank you very much.
Excellent. Thank you, Dr. Koffler. You not only framed the stakes, you gave some concrete actions on where we should focus. And thank you for your honesty to share where the world perhaps has been and where we need to be in the future. We're going to go to some interventions and some questions around a few areas of intervention. We want it to be an action-packed session. We don't want to talk too much. We want to talk and act. So I'll go to our panelists. And Madame Winnie, you allow me to call you Madame Winnie because as an African, I have African sensibilities. So I'll allow you to give two minutes response to these questions. So we know the impact of current budgets and how we have to ensure that this innovative finances doesn't leave behind the least of us, those who don't have as much voice in our economic sector. How do we transition towards a new global financial system that ensures that we incorporate the most vulnerable and we can partner with governments who want to be an ally?
Thank you very much. And I want to congratulate One Campaign for convening this very important meeting. And thank you, Dr. Koffler, Parliamentary Secretary of Germany, for the statement you have just made. Global health is a global public good. And Germany says it and does it with your resources. So thank you. To answer your question, global health has been very much anchored in global solidarity. Countries agreeing to work together to deliver on health. And it's been driven very much by aid for the developing countries. You mentioned it. But now we're seeing that aid tumbling very fast. I could give you figures, but I won't. But that suddenness, that rapid decline is costing lives. Let's be clear about that. I could tell you stories of people who have died this year The people are dying. So the first thing we need to do is to organize a planned, a responsible transition from a model of aid. We've seen the vulnerabilities of aid. And now we want to go away from that, but we must do it in an orderly way that's not costing lives. So aid needs to stay there to keep as a scaffolding as we transition. In transitioning, we must solve the problems of the old model. We must not bring back the problems of the old model. One of them was that of a reliance on external assistance. And within that, of a reliance on a handful of donors of aid. In the area of HIV, where I work, when the United States paused their development assistance in February, in the whole global response on HIV/AIDS, the United States was shouldering, the development assistance was shouldering, guess what? 73% of the total burden, one country. The rest of the world was shouldering the 27%. That wasn't right. So that over-dependence on one country, on a few countries, and over-dependence of the developing countries, we have to solve it. And I have some ideas on how. We'll come to that. But secondly, in those countries that were over-dependent on aid, what happened in the area of ours, for example, HIV, was the creation of parallel structures where this money for HIV was driven, while the rest of the health systems were crumbling. We must solve that. We must integrate, build one health system that addresses vertical diseases, but that's one system that delivers cost effectively. These are things we are doing. We are working with countries, but first and foremost, we must do it with a plan that's orderly, that's responsible, and that doesn't cost lives. It shouldn't be a retreat, a sudden retreat, but it should be a planned transition.
Thank you.
I will talk more about it later.
Absolutely, but you've given us some good food for thought, just how to make sure we don't, in the redesign of aid, parallel systems, look out for that, and over-reliance. Let me go to you, Dr. Jean. With so many countries in Africa at risk of debt distress, after COVID, we really saw that physical space shrinking. What concrete steps can be taken at the regional level to protect and expand health services at this time?
Thank you. Let me thank my friend, Dr. Barbara Koffler. I can still remember the discussion we had last time and the photo you took with the book that we developed. Let me be clear on that. Africa didn't wait for ODA CAT to take action. September 2024, Rwanda is affected by Marburg outbreak. I went to Rwanda. I'm in dialogue with President Kagame. I said, the way I see things are moving, we need to be proactive. September 2024, there was not election in the US, there was not election in Germany, there was not election in other countries. It means no one was talking about ODA CAT. But we started to take action. What was unfortunate, we decided to call for this meeting in February. Then December, January, you know what happened. Then when our meeting was taking place in February, it was like we are reacting to some decisions. No, we're proactive. This is the first point. The second one, we are talking about what we call the global health system that is fragmented, duplicating actions, and not so efficient as we want in Africa. From one side, we have this global health architecture that doesn't help you. From another side, people, they try to forget that the first source of funding of health system in Africa is not ODA. The first source of funding of health in Africa is out of pocket. That is making people more poor than they were before. When we started to address this issue, we didn't address that vis-à-vis ODA, we're addressing that vis-à-vis out of pocket. And we said, how can we restructure everything by not begging people, by taking our responsibility? This is why we came with the Africa Health Financing in a New Era. Some of you are calling that Green Book. This Green Book was the starting point. It's the most comprehensive document that Africa developed to address the issue of health financing. More domestic resources, more innovative financing, more blended finance. But the fourth one, people are not talking more about it. Good governance. Avoiding corruption, avoiding fraud, putting in place a system that can help us to have reliable data. This is what led for the meeting, and my friend Dr. Barbel Kofler talked about it, that my leader, President Mahama, organized. Now we are moving toward what we call the health sovereignty. President Ramaphosa organized a meeting a few weeks ago together with some head of state to talk about the content. When we are talking about health sovereignty in Africa, we are talking about a number of components: financing, local manufacturing, data sovereignty. Why data sovereignty? Colleagues, when the US funds were cut to Africa, data were also gone. I called ministers who told me we don't have access to our data. Now we say we need to manage our own data. And the fourth component is this governance we are putting in place. Together, we are now saying Africa is ready. We don't want to be invited. We are the co-creator of this global health architecture. I'm not invited here. I'm here because I'm leading an agency, having a strong voice, knowing what we are doing. We become co-creator for World Health Summit. Thank you.
Excellent. Thank you. Thank you for laying out that proactive stance that Africa had from the beginning and also sharing what the sovereignty looks like. Dr. Thomas, I want to come to you on the private sector vantage point. So what is your perspective of these significant cuts happening, the funding challenges, not just in the countries, in African low and middle income countries, even in Western countries? How do governments and your industry, how do they respond to this moment?
Yeah, first let me recognize that if you look at access to medicines or even basic healthcare, we have a global challenge in the world because even prior to this funding cuts, about 50% of the global world does not have access to basic healthcare. It's obviously something that we need to address and we need to change. Now, the whole situation has become a lot worse given all the cuts that happened in this year. I can say we've, in the past, made huge progress, for example, in the detection of HIV and treatment of HIV with the 1990 program, where also we played a significant role in that in Africa, but also we expanded that to hepatitis C, to cervical cancer screening, et cetera, et cetera. So there is, a lot of opportunity there, and at the end, I think the diagnostics actually builds the basis, because if you don't have the diagnostics infrastructure, it becomes very difficult then in terms of treatment, because if you don't know what it is, you cannot treat it, right? So just to say that there was a lot of progress, unfortunately, we're taking a couple of steps back. So for me, there are two elements that are really critical. One, I would call global solidarity, and the second one would be local ownership. Global solidarity, because if we are in a world where every country optimizes for themselves, we're not in a good world. And when I think about my children growing up in a world like that, I wouldn't want my children to grow up in a world like that. I would want my children to grow up in a world where the world works together and tries to help each other. And I think that's important, because also when you look at richer countries can't expect, for example, to have the same prices on medicines or diagnostics as poor countries. They cannot then say, we refer back and we say, we want that price. Because if we do that, then there are only two options. One option is that basically as a company you will not be able to invest anymore in innovation because based on those prices you cannot innovate, or what happens is you have lack of access. And I think this kind of global solidarity is important beyond also what we had with USAID and all these other kind of foundations. The second piece is, for me, local ownership. Because the problem when you just rely on donations is you actually don't implement things that are sustainable and long-lasting. And I think both things have to happen at the same time. And just recently, when we had this meeting with Bill Gates on all these activities, we said we also have to invite some African leaders to discuss about co-investment opportunities, where each of us have a skin in the game, so everyone needs to contribute. Because at the end, if you don't have a skin in the game, people also don't value it as much. And we could see it in a way where, there was medicines delivered, and these medicines sit somewhere, and, it runs out of the shelf life because it's not distributed. And I think that would not be the case if you didn't have skin in the game. And I think also economically, for Africa or other countries in the world, it's important to invest in health because it gives you a return in terms of economic growth. Every dollar invested gives you a return that is 4 times. Look at Germany. Germany, recently with some exchanges with the government, they were surprised to hear that the #1 industry in Germany is no longer the car industry, it's the healthcare industry. It's a future industry. So if you invest in health in your country, you can build up an industry, you can build up jobs, you have a healthy population that's a productive population. So you have to also take this ownership. So I think you have to have both.
Thank you very much. And you gave us the 2 elements of what this new design is, the global solidarity, as we've been hearing, and also the local ownership. Really appreciate that framing. I wanted to go to you, Dr. Saia, because you are leading the Western Pacific. So there are countries like the Western Pacific, they're smaller and more vulnerable, and they also have the limited fiscal capacity. We're seeing that on the continent, but we're seeing that there too. How are they responding to this moment?
Yeah. Thank you, moderator, and I want to thank the organizers for convening this important at a critical time. I was in Geneva earlier this year, and I was asked to speak on AI and digital health. And then I questioned myself. I'm a surgeon. What is a surgeon doing in AI or digital health? And then I was asked to talk on oral health. And the same thing. Now I'm asked to talk on health financing. Numbers, I'm not good with numbers. But I think what is important here, that what we are discussing today, what we have discussed already, just on one purpose, to better serve our communities. And for the Western Pacific region, to better serve the 2.2 billion population in the Western Pacific region. As someone who has witnessed firsthand the fragility and the resilience of small island states, and to better serve them, I think we need to start from mindset shift. We need to start talking that health is not a cost. Health is a capital. And we need to be clear on that. It fuels economies, strengthens governance, and anchors national resilience. For Pacific nation, where vulnerabilities are magnified by limited resources, economic shocks, and now accelerating impact of climate change. Small island developing states must prioritize health as a strategic investment under the universal health coverage. We must invest in primary health care to achieve the universal health coverage. You know that a resilient health system not only saves lives, it stabilizes societies and drives development. And I think that is important. We need to move from dependency to empowerment. This is the time to build a domestic or sustainable domestic financing. No longer relied because of the financial situation that we are facing. So we must strengthen public financial management, build trust in the community, ensure accountability and transparency, and address corruption. You get the trust of the community, they will provide whatever the circumstances. We need to address structural economic challenges and support recovery sectors like tourism. We still need to sustain bilateral and multilateral support, including concessional financing for infrastructure and coverage. We also need to innovate financing for climate resilience and renewable energy. Build a health system that is climate resilient, healthcare facilities. There was a survey in 14 Pacific Island countries. 62% of the healthcare facilities is within 500 meters from the sea, putting them at risk. With the sea level rise, in 2050, some of these health facilities will be underwater. I think it's important to build a climate resilient healthcare facilities, just to ensure that they are well equipped to save lives. Yeah. Basics, water, sanitation, disposal. And I think that is important. Reform tax system. The WHO best price. You know, you raise tax on alcohol, on tobacco, and sugary drinks, and unhealthy food. WHO best price has proven that this works. It reduces the consumption. Not only that, but it's a powerful lever to also address the NCDs that sometimes often called that the Pacific is the capital of NCDs. We need to address that. In the Western Pacific, there's still high alcohol consumption and still remain a concern. After next week, on the 20th of October, we will convene our regional committee meeting. And this is the best and the golden opportunity to bring our member states on accelerating the Global Alcohol Action Plan 2022-2030. We know raising tax on alcohol reduces the consumption, and it also generates vital health funding. And I think it's also important, as has been discussed, that we need to invest in health, intelligence, and data system. We need a robust system. Without those, whatever planning and advocacy will definitely fail. Yeah. You need this. You need an informed decision and very timely. And lastly, as I said, primary health care. Member states, they need to ensure that there is health insurance, reduced out-of-pocket expenses for people if we are serious about universal health coverage. And the primary health care, and I want to bring this example that I visited in the Philippines. The Minister of Health embraced that concept of primary healthcare. So he transformed one of the community hospital into a primary healthcare center. He removed all the beds, only 4 beds left to stabilize patient and transfer to the referral hospital and provide all the services that is needed by the community. And when I visited the center, the testament from all of them, the elderly people and those in the community, that before the transformation happened, they have to travel long distance to the hospital, waited long hours to be seen, and just to get the services that they are getting now in the center.
Thank you, Dr. Saia. That's a powerful example of what's happening
Thank
in
you.
the Philippines. A round of applause for Dr. Saia. And I think 2 things you brought to this conversation. One is on community ownership and accountability, and we'll come back to that because I do think increasing...
Can I just finish with this?
Can we come back?
Empowerment begins with ownership. Ownership begins with political courage. And I think this is important. Communities should take ownership.
Absolutely.
Countries, member states should take ownership and prioritize what is important for them. So, for me, let us build a financing models that protect and uplift the vulnerable small island state, not just for today, but for generations to come.
Thank you very much.
I stop here.
Thank you very much, and we'll come back to you. Dr. Mónica, I wanted to come to you. Spain has been quite a key player in multilateral establishments like Gavi that really reinforce the global solidarity and ownership we've been talking about. So in today's context of tighter budgets and competing global priorities, how does Spain and other progressive governments help build this new architecture that has our global solidarity and responsibility included?
Well, thank you very much for this invitation to this important panel. Let me start with the sentence of Dr. Barbara Koffer, rethinking and addressing the global health, the new global health system, including its financing system. It's not only a right thing to do, but also the smart thing to do. So we have to collaborate, we have to take all the intelligence of all the actors and actresses for all over the world to rebuild this architecture. Spain welcomes this important conversation because continuing with business as usual in international development funding will not be enough. We need a combination of fair and predictable domestic and global sources of revenue that can protect health budgets both in times of prosperity and in times of crisis. We are now facing a financial crisis for global health, but we are going to turn it into an opportunity, as we have said many times. Let me put 3 topics on the table that my colleagues have said before. First, we must prioritize fair and equitable tax systems. In Spain, as you know, our healthcare system based on public funds, with the majority of resources coming from general taxation. We have a universal healthcare system. In addition, we have well-designed health-related taxes with tobacco and alcohol and sugary drinks. But I think that to spread this universal health coverage is a need now as a right. Second, we need to support global solidarity contributions, innovative financing mechanisms to collect small, stable amounts at a scale that can make a meaningful impact. For example, the solidarity levy on airline tickets that founded UNAIDS is a powerful example. And third, we must reframe health not as a cost, as they said, but as an investment and a driver of inclusive economic growth. The World Health Organization's Council on the Economics of Health for All calls for aligning financing systems with public purpose by valuing health, reshaping financial frameworks, and strengthening public sector capabilities. Spain strongly supports this vision, which places equity at its core. In short, fair domestic taxation, target global levies, and mission-driven public financing are all essentials and complementary pillars. Spain is committed to working with partners to broaden the base of health financing beyond traditional development assistance to safeguard essential services and to invest in a health economy that delivers, that truly matters to people. Thank you very much.
Thank you very much, Dr. Monica. Thank you for sharing that out so clearly. You know, at the One Campaign, we convened global leaders and African leaders a few months ago actually, and we talked about what concrete levers can be used. Dr. Saia mentioned it, Dr. Monica mentioned it, folks have mentioned it. One of the first ones that came out loudly was health taxes and duties. About 90% of African countries already have some sort of health taxes and duties, but that design is really important. Dr. Kaseya, I want to come to you first. So we know a bunch of African countries are already implementing these, whether it's tobacco, sin taxes, alcohol, sugar taxes, some countries fast food taxes. What lessons can African countries draw from, and what lessons can the rest of the world learn from African countries as they've implemented these taxes over time?
We are moving with this agenda of innovative financing. But we are not talking a lot about it. A country like Ethiopia, they doubled their domestic budget. A country like Ghana, they created the Mama Care using some scheme that they have. A country like DRC, they decided to put 2% of all goods imported for health sector. That is giving $1.4 billion additional dollars per year. So many examples across Africa. What we are doing now as Africa CDC, we are recruiting public finance management specialists to be posted in each country because ministers, they told us, we are lacking this capacity. Someone who can help us to bridge Minister of Health with Minister of Finance and Budget and Planning to make sure that we know where we are going. This is the first one. Why are we, the second one, why are we leveraging resources? Only 6 African countries have well-costed strategic plan till 2030. 6. How do you want to leverage resources even if you don't know what you will do with that? This is why we are supporting countries to put in place strong and well-costed strategic plan. I'm flying on Tuesday in the US to see how, because Africa is part of the new program, how we can support countries to have this plan. That will help also the dialogue we are having. Another lesson is how can we leverage on AI? And this is why we have this strong digital transformation agenda that Africa Citizens are releasing. It will be approved in February by head of state to make sure that we can track the impact and show the impact. Maybe, because I will not speak again, I have to say that. You will speak again. I will speak again, but, oh, she left. This is what I wanted to tell her. But even in absentia, now I'm leading the replenishment of Gavi Global Fund Pandemic Fund. We did very well with Gavi. I wanted to tell her, but I will send her a WhatsApp. I want Germany to make me proud today. During the opening ceremony, I'm challenging Germany to give at least $1 billion to Global Fund. If this is the case, I will give her a public hug. That will open the door for me when I fly to the US on Tuesday to say to the US, please beat the Germany.
Great. Thank you very much. So 6 p.m. today,
more,
the German pledge will be made. Please make sure you're there to make sure we see if there's a public hug being given. Madam Winnie, you know, taxes can sometimes affect the poorest who are already hit with so many challenges. So how do we design taxes and duties so they're not penalizing those who are already economically on the bottom ladder?
Thank you. You've asked a good question. And there was an earlier discussion on the sin taxes, tobacco, alcohol, and all of that. They are important, but we need to understand that if you're going to build if you want to say you want to build a room like this, and someone comes and says to you, I'll give you 6 tins of paint to paint it the color you want, you say, thank you. It's a contribution, but it's not fundamental. These sin taxes, yes, they are good, but if they are successful, they actually generate diminishing returns, if they are successful, because they discourage the youth. Secondly, because they are an indirect tax on consumption, they tend to hit the hardest, the poor the hardest. So let's talk about what we really need to do. The low-income countries, particularly of Africa, have been hovering at about 16% of taxation relative to GDP, right? 16% of GDP. That's how they've failed to raise more domestic revenues for the last 15 years. Why? That's a question to answer. Why? First, those countries, most of them African, with crumbling health systems, are not able to raise more money because there are issues in the global economy that don't enable them to collect all that they could. For example, we have a serious challenge of tax dodging, that companies do not pay their fair share of taxes where they produce because they can't, they simply can't. The rules have been written in ways and ways that enable them to externalize profits without paying taxes, to tax havens, to offshore properties, and so on. So first, there is a need to close down the tax loopholes. There is a process going on at the United Nations, a negotiation of a UN convention on global tax collaboration. We need all the countries, particularly the rich ones, where the big companies come from, the global companies that are extracting without paying fair share of taxes. We need them on the table to agree on closing tax loopholes. Then we'll start to see more resources coming in as domestic. But that's only one. Secondly, the same countries continue to tax regressively. They do not tax enough wealth and high incomes. This is a serious issue. Even the most conservative advisors like the IFIs are now advising the same governments that move on to taxing your high-income earners and taxing wealth. It's difficult. Of course, when you talk about that, you get a fear of capital flight. If I tax wealth, then wealth will move to another country. So again, you need some kind of collaboration on moving on more progressive taxation. Brazil last year at G20 attempted to move the world in this direction by proposing a minimum tax rate for billionaires. This would have been a way to get countries to hold the line somewhere about taxing wealth. So no country loses because it has taxed and others haven't. So there was some general agreement by the G20, though it wasn't specific. But now, there was an agreement that should be there should be more transparency, and there should be more collaboration to tax wealth. But then now, South Africa is leading G20, and they are moving forward too. President Ramaphosa has set up what he calls an extraordinary committee headed by Joseph Stiglitz, Professor Stiglitz. I'm one of its members, and it's about how to tackle global wealth inequality. And this question of progressive taxation is on the table. Because do you know, if the world was to tax just the 3,000 billionaires, the world could raise 2% tax, $1.7 trillion. Trillion. Just a 2% tax on 3,000 billionaires. That could fund global health, climate adaptation. It could fund education where there's girls are not going to school. It's so much money for global public goods. And you see, this would just, because we have shifted instead to saying, let rich people give what they can. Philanthropy, I have a problem with that. It's good, but it's a problem. Because you're giving elites the power to decide what will be funded and what won't be. That's not the way to fund global public goods. They must be paid for from taxes collected from everybody. And those who benefit the most must shoulder the highest burden of taxation. So global taxation, that's progressive. This is its time, and we are moving in that direction through G20 and through the UN. But let me say one last thing, again on taxes, that you see, when we are taxing and we talk about innovative sources, we are actually saying that what Mónica was saying, that the real taxation, the main ways of taxing, which is to look at who is raising most income, who's depending on public services the most to raise money and to tax. You're moving away from that and you're trying to find other ways of raising revenue. So let's focus on progressive taxation and not on taking a little more money from X and Y and so on. So progressive taxation, closing tax loopholes, and pooling global resources for global challenges.
Madam Winnie has put another innovative mechanism on the table, sort of progressive taxation from the rich. So we will add that to the
Nationally
portfolio.
and globally.
Nationally and globally, correct. Local ownership. I wanted to move to another intervention we talked about, which was diaspora capital. So the diaspora is bringing in a lot of resources to many low and middle income countries. And this usually is not channeled into a specific source. It's a one-to-one giving. Dr. Saia, I wanted to bring you into this. The diaspora remittances are a powerhouse for the Western Pacific. How do we channel this into health financing or supporting healthcare in that region?
Yeah, thank you, Sarah. I think this is very important for small island states. And in the Pacific, you know, migration doesn't cut ties, but it strengthens them. When people migrate overseas, they carry with them their roots. Whether you are in Auckland, or Sydney, Australia, or Los Angeles in the US, you know, our people remain deeply connected to the island. And, you know, sending remittances, sharing knowledge, and supporting communities. This is more than financial, it's familial. And I think it is important that some of the small island states like Niue, like Tokelau, Cook Islands, Samoa, Tonga, the diasporas often outnumber the home population. There is more outside than within countries. And this presents a powerful opportunity for development financing, but also a responsible or responsibly to manage it wisely. So the question is, even myself, a lot of my families are in this group of diaspora in the United States. And amazingly, some of the small island states, the highest income to the country are from the remittances. And that is so powerful. But you raise a very important question, the sustainability and the use of these remittances. So personally, to ensure the sustainability and avoid over-reliance, we must put something, a system in place. I think it's important that we set fiscal safeguard, that we use the diaspora funds for strategic investment, not recurrent spending, to avoid fiscal risk. We need to diversify the funding. We need to strengthen sectors like tourism, agriculture, and renewable energy to reduce vulnerability. But one of the important things here is to institutionalize the engagement. We need to create a formal pathways for diaspora, their contribution to the government, their skill transfer into the country, and return migration. When I was health minister in Tonga, I was asked this question. When I was losing my nurses to New Zealand and Australia, and I was asked this question, what do you do about it? And I said, I won't stop any of them. I will support them. And it's the saying, you train your workers well enough so they can leave, but look after them well enough so they don't. So, and then I said, they live in their hundreds, I train in their thousands. Because I know one day they will return, better equipped and better serve the communities. And I want to give you this example. There is this Tongan in New Zealand, one of the top colorectal surgeons. He was on scholarship, undergrad. He never came back to Tonga to work. He stayed in New Zealand, did all his training, the fellowship training, and become one of the top colorectal surgeons. He is now returning to Tonga 6 to 8 times a year to operate on complicated cases that will cost thousands of dollars for the ministry and for the government. This is the importance of, the diaspora, return of investment that you have invested, better equipped to better serve.
Dr. Saia, I think you had one mic-dropping line, which was you train them well enough that they want to stay, that they should stay, but you resource them well enough that they don't want to go.
No,
you
I
train
said, train them well enough so they can leave.
Go. Right, but you
But
resource them.
Treat them well enough
enough.
so they don't leave.
Excellent. I think it's a great framing. I know, Madam Winnie, you wanted to come in on that.
On remittances, I have a slightly different view.
Okay.
You see,
Let's get a divergence of views here.
Remittances are a growing flow of resources from migrants to their source countries, to their families. This has grown and grown as migration has grown. But primarily, this is people's private money to their families.
Right.
Research shows that they tend to, and these are very ordinary people doing the low-end jobs in the countries they migrate to, domestic work, cleaning, all that. These flows of money do 3 things mainly. People send them home to their families to pay for health of their families, education of children, and building houses for their families. Now, but this new idea of crowding in remittances This is all about crowding private money into building public health systems. I'm okay if you are the state borrowing private money to build a public health system. But when you're inviting it in as money, as equity from another, so into a kind of public-private partnership, the objective of health for all is often compromised. So I would like to see remittances as funds, governments thinking about how do you draw on these as big funds that the government is borrowing to build a public health system, but not asking migrants to buy a stake in the public health system, because that won't work. We've seen how public-private partnerships for health have ended up concentrating money for those who can buy health and not for those who need health the poorest.
And Madam Winnie, I think one of the structures of remittances is it should follow the same pathway it usually does, which is I send it home to my sister to pay for healthcare, education, building a house. I don't move that to a state. I continue sending it, but perhaps buying insurance instead of sending it for one hospital bill. So that's a design question, because this moment calls for us to question some things, but also follow the pattern of how people usually share remittances. Dr. Kaseya, I wanted to bring you into this.
Yeah, look, last month I got a call. My mother is in DRC. They wanted me to send 3,500 because she was sick. You can imagine. But if we had in place the community health insurance scheme, I would not send this money. What we are talking about is to see diaspora being sensitized, to see countries putting in place a strong community health insurance scheme. Rwanda, 80% of people are under the system, and they are paying less than $2 per month. They have access to health services. Why we cannot do that everywhere? Today I was talking with someone, you will see the announcement that we'll make, how to put that in place. Diaspora still have a role. Remittances can also be channeled to support some aspect of public health. We are talking about blended finance. What it means? It means capital that is coming to be invested to build local manufacturing, complementing what the government is doing. It's a broad discussion that we need to have, but we are saying it's a shared responsibility, government to put in place some policies and creating the conducive environment, and diaspora also seeing that their money is not misused, but they are contributing to invest and to build the system.
And I think Madam Winnie provides guardrails for what to watch against. But I think there are opportunities that we can draw into, because this moment really calls for us to think through what opportunities exist. I wanted to move to...
Can I just add on this? I want to thank you for bringing this issue for discussion, because this is huge for some of the small island states. But we need to discuss it and see a better way of addressing, rather than just sending it to build a house, send all this. And I think it's important that we need to build a system to track the inflow of the remittances and measured impact. What is the impact of those remittances done? Fostering trust and accountability. Because our strength lies in our people, not only at home, but abroad. I think diaspora support is a blessing, but we must manage with care. That is important. Because with the life's right safeguard, the diaspora financing can be a bridge to resilience, not a crutch of dependency. And I think that is very important. And thank you for bringing, and I think it has been informal. We need to formalize and better use and see the impact, because they send millions. And like what I said, the highest income, some of the islands, small island states, is from the remittances. But what is the impact? I think we need to formalize and make sure that we better start talking about this
And that's,
from now on.
and that's the challenge we have in this moment. How do
Yes.
we design something
How?
that works for all of us? I wanted to move to another area and intervention, which is healthcare. So when we talk about healthcare, it's a cost item for many governments, right? It's how much we're giving to, it's an expenditure and it's an expense. How do we turn it around to be a revenue source? Dr. Barbell talked about the investments and how we can view healthcare as an investment. That's correct, but tactically, when you go to a minister of finance and he's kind of doing the budget, he or she is doing the budget, how does healthcare turn into that revenue source? Dr. Thomas, I wanted to pull it to you. I know it's a challenging question, but I know you're equal to the task.
Sure. Well, let me first say I'm not a politician.
It's fair.
And, but I lead a company, right? And when you lead a company, there are certain things that are probably in common as to leading a country. I think simpler than leading a country, but you also have a finance minister, which is my CFO, and then I have a lot of ministries. They all come to me and they all tell me they need more money, they need this, they need that. So you have just that constant situation. But one thing that I've always learned, leading a company now for quite some time, is the one thing you need is growth. Because if you don't have growth, if you have to just manage on costs, it's very hard to manage. Simply because salaries go up, there's inflation, there's other things going on. If you don't have top-line growth, you have an issue. And so focusing on top-line growth, I think, is very important. Then you have to identify which are your growth areas. Healthcare is one of the growth areas, clearly, and I think most governments have identified that. Then, people say, okay, we have to invest money. My finance CFO or my finance minister tells me, well, we don't have enough money. Then I said, we have to find it. And we have to find it, we have to look at exactly where we spend our money. And, I can just say, having seen the efficiency of governments, and I would say companies have their thing to do as well, but if you look at the efficiency of governments, there's a lot of opportunity to channel the money into the right areas. So I think that's what you then do as a, kind of being responsible for a country or for a company, is you try to find the areas where you need to invest in terms of growth, because when you have more top-line growth, you can also just accept more cost growth. You look at how do you finance the growth by taking out the inefficiencies in the system, and there are many. And these days, you also look at how can you leverage technology to accelerate things, to make things more cost-effective, etc. So, for example, we use across all our value chain, AI, increasingly more, to really cut out redundancy work that is, quite frankly, sometimes boring, so that you can actually resource other areas in a better way. And then you can go even further. I mean, if you think about 5 to 10 years from now, what kind of innovation is going to come? There could be opportunities for certain countries also to leapfrog developed countries. But you have to invest in those. So it's really investment in growth. And I think healthcare is clearly up there, because healthcare contributes to a population that is productive, that can do work, that generate productivity in other areas. But itself, it is also an environment or an industry where you will continue to have growth. And why? We have an aging population in the world. There will be always more needs for health. So this investment is needed.
That's excellent. I think growth and inefficiencies. And the world has an aging population. Africa has a greening population. Yes. The world is having needs. Africa is having, population to support those needs. So I think there's a match made there that we should take advantage. I wanted to open this particular topic up because, yes, Dr. Jean, you wanted to say
your
something.
question is clear. Thomas is not a politician. I'm not a politician, but I'm a political person because I'm elected by head of state. Look, when you had to work in the government like some of us, we know every single day the Minister of Health is lobbying the Minister of Finance to look for resources. How can we reverse that? This is the question. Switzerland is exporting 35% pharma product. Africa can reverse that using two opportunities. The first one, local manufacturing. We are talking about a market that will be $240 billion in the next 15 years. This money is going somewhere. We can capture these resources. When we start to build this market, the Minister of Finance will start to follow the Minister of Health, because this is where money will come from. The second one is the digital transformation with AI. Now in Kenya, they managed to put in place a system attracting $400 million from a partner, a private sector, complementing that with additional $400 million, creating a system where when you have access to health system, you are paying 2% to reimburse this debt and to generate other resources. Now it's the Minister of Finance talking with the Minister of Health. How can I capture some of this money? You know, now there is respect between Minister of Finance and Minister of Health. This is what we are doing today. And I'm dreaming by the end of my term in Africa CDC to see Minister of Finance following Minister of Health.
Oh, that's the dream right there. And Madam Winnie, as you come in, audience members, we're going to be asking you for your questions. I'm looking at the time, making sure we're keeping close to time here. So a colleague is walking around the aisles. I see a question over there. So please collect those questions so we can get the voices of the audience as well. Madam Winnie, really quickly.
Yeah, quickly. I want to agree that we have to move away from seeing healthcare as a cost to contain and look at it more as an engine of growth. It is. Of course, the colleagues have ably argued that a healthy population is a more productive population, more innovative, and all of that. But I want to focus on the healthcare sector as actually a sector that is one of the fastest growing in the world today. They've mentioned areas like digital, pharmaceuticals, biotechnology. So countries that invest in these areas are actually investing in a knowledge economy, in skilling their people for high quality jobs. That's why this agenda of Africa to build local capacity, to produce medicines, to grow in the health sector production area is so important. It's about industries of the future. But I wanted to say also that, you see, we are all sitting here afraid of AI and how it's going to lock out people from jobs, displace people. This is a sector, the health and the care economy, are areas that are labor intensive, that are, and I'm talking about elder care, child care, mental health, community health. All these are areas that are not easily replaceable with technology, that will need people working there. I will not let my grandchild be looked after by a robot. I will retire and raise my grandchild. So we are talking about a sector that is low carbon, that is labor intensive, that is gender equalizing, because these are millions of jobs that will be done, and if done well and paid enough, will be equalized, because they're mostly done by women and girls. If women are paid well in the health and care sectors, you are equalizing. You are getting more people into work and paid well for the jobs that they are now doing as volunteers.
Yes.
So
AI theme has been...
This is a whole growth area that will lift countries out of poverty. And also for the rich countries where, you know, we have a care crisis. When I go to Boston, I find there women and men who were in our countries highly qualified health professionals, just now wheeling one rich woman because that rich woman is paying her for care more than what she's paid in a hospital as a high-level clinical nurse. So there's a brain drain that's a result of the underpaying of care services in the richer countries. So
I think-
once we pay them well all over the world,
Back to resourcing.
we grow the
our workers well.
economies of
Yes.
rich and developing countries.
And I think a pattern and a theme has been on AI and the technology opportunities there. I'm just watching time. I'll just move. Thomas, I see you wanted to come in really quickly, if you can come in.
Yeah, I just wanted to say, because you mentioned it, and I just wanted to respond to that. I think one of the key problems is the silos in the governments and the different ministries, right? I think you have to work across the different parts of the system much more effectively. And, one of the things that you can't have, and I've seen that also now taking a company perspective, if you have people with egos sitting in certain roles and they're not willing to budge on their budget because they identify themselves based on the size of the budget, you will never have kind of a situation where you're going to improve on the system. And that's why I can only say what for me is very clear as one hiring criteria. I don't want any people with egos. I want people that find solutions overall, and if it means that they have to sacrifice in their function for the better, for the overall, this is how I expect people to lead. And I think we need, between governments and between the different parts of the government, a bit more openness to shift budgets.
Yeah. So reducing egos helps us more collaboration with removing the silos. The one last thing I want to talk about before I go into this question, there's so many questions here for us. Dr. Saia, I'll come back to you at the end to think about what is the action we want to keep. Dr. Mónica, Spain has been remarkable on health for debt swaps because 25 countries at risk of debt distress, they're paying more to pay their debt than they are to invest in health and education combined. So we know that it's tone deaf to come to countries and say, hey, do more for health when we don't have innovation or looking for a way to reduce their debt. How are you seeing this moment? How can we scale this kind of intervention as Spain has done so remarkably?
Yes, for countries experiencing financial distress, debt for health swaps offer a way to transform debt obligations into direct investments in health care systems and services. Spain has practical experience in this area through the Global Fund's Debt to Health Initiative or agreement with Cameroon, with Democratic Republic of Congo and Ethiopia, redirected 15.5 million towards fighting HIV, malaria, and strengthening health systems funds, and would otherwise have gone towards servicing debt. So we are now scaling up this model. In July 2025 in Seville, Spain, and the World Bank launched the Global Hub for Debt Swaps to help countries replicate these agreements more quickly and at lower cost so that more debt repayments can be redirected to health and climate priorities with strong accountability.
Excellent. Thank you very much for that punchy response. A bunch of questions have come in for all of us, and I know we are shy at time, but I've tried to group them as much as possible. One is around CSOs, how CSOs can support accountability within countries so that it's not lost to corruption and bad governance. Dr. Kaseya, let me pass that on to you. What's your response to that?
I come from a CSO. In my career, I had worked for a CSO. And I know the role of a CSO to not only support, but to lead this agenda. This morning, I was having a session where I say, CSOs, they become the co-creators of accountability at country level. It's critical because what we are not doing very well is our people are acknowledging services that we are giving to them. And this is the role that CSO they have to play. It's fundamental that in Africa, some countries, I come from a country where 60% of health services were delivered by faith-based organizations. Mm-hmm. They are CSOs. It means they have strong voices. This is why we are advocating to see government working closely with CSO in Africa.
That's helpful. Thank you. Thank you. Yes, we can clap. Dr. Thomas, there's a few questions here on the pharmaceutical side, which is, what more can pharmaceutical companies do? Because questions are raised about IP, they're raised about sort of resourcing different parts of the world. Can I ask you to just speak, we're pressing you, what more can pharmaceutical companies do in this moment that we're in?
Yeah, I think, first of all, it's about innovation, because if you look at the last 100 years, we've been able to double the life expectancy. And so with more innovation, you can improve outcomes. And with a lot of innovation, you can actually reduce also cost of care. Especially also if you go more towards prevention, etc., then you get into a situation where you don't actually create the cost in the healthcare system in the first place. I think that's very critical. The second piece is, and I just want to mention that around IP, is I think there needs to be an incentive system for companies to be innovative. I mean, we've seen systems in the past in certain parts of the world where it was very clear that if there's no such system, then innovation will die. So in pharmaceuticals, you have about 10, 12 years in which you have patent protection. And then these medicines become generic. And I have to say, if you look at just the next to the end of the decade, you have about medicines in the range of 250 billion that will become generic by the end of the decade. So, there is also then that opportunity to reinvest that money as these become then generic. So I think that's also something to keep in mind. Yeah. As a company, we try to do tiered pricing. So basically, price it much lower in countries that otherwise could not afford the medicines. Now this I find threatens right now, right? And I find it threatened because of lack of solidarity between countries. Because if now rich countries, and I don't want to name those countries specifically, but there are also countries in Europe around that say, well, I want to pay the same price as some country X, Y, and Z, then it becomes very difficult to fund innovation. Because for pharmaceuticals, it's not the production of the medicine that's really the cost. The cost is really in research and development. And for example, we spent 14 billion in research and development, and at the end, only 1 out of 10 medicines makes it. And so if you look at the average cost of a medicine that's being developed today, it costs around 4 billion. You can't have a cost-plus model. You have to have a model where rich countries accept to pay more so that you can give it to a cheaper price to poor countries. Yeah, and unfortunately, right now, with all this protectionism and all this, every country first, I see that very severely challenged, and even by countries in Europe, I have to say, and that's a big concern.
So putting global solidarity in the middle of this whole conversation. I wanted to turn to my panel.
When they are conducting clinical trials in Africa, they have to manufacture in Africa.
There you go. Sure. Well, maybe Dr. Kaseya, you can start with the first action. Dr. Kaseya, we have each of our panelists, I want us to go with one bold action that we can achieve in the next 12 months. One, quickly.
In the next 12 months?
In the next 12 months, we should be able to achieve it. I wonder, Dr. Kaseya, should we start with you and then go to Dr. Saia?
We are already achieving health sovereignty, plus multilateralism. I hope I will give big hug.
Okay, so there's a hug pending. Dr. Saia, one bold action in the next 12 months we can do together.
I want to see small island states take bold, unapologetic step to significantly raise taxation on tobacco, alcohol, and healthy food.
Okay, that's a good one. So raising taxation on sin taxes. Madam Winnie, one bold action.
Well, given what we've been discussing, I would look in the tax area for one agreement that could increase domestic revenues for the low-income countries, particularly of Africa. And I think one of big agreements that could be achieved here is that UN framework on global tax collaboration that would help to close the tax loopholes. Africa is losing about $88 billion every year through illegal financial flows. Some of that could be reined in.
To the UN. Dr. Mónica, in the next 12 months, one bold action.
Only one?
Only one.
I think financing, financing global health is financing justice, is financing rights, is financing future. Redistribute health is redistribute hope, and the most important thing, the wealth, the most wealth in our lives, that it's the health. So rethinking about the financing of the global health, I think, is the most important now.
Excellent. Dr. Thomas, one.
Yeah, I think we should look at maybe those countries that have been successful or are making a lot of progress, and I think there are some examples also in Africa. And then we should try to replicate that. And there is a commitment from us to work with all the different leaders to find models where there's a joint accountability and not just a one-sided accountability.
Excellent. Thank you all very much. In conclusion, in this fragmented world we find ourselves, we know that what we will need are real tools on the table. There's no silver bullet, so we need a portfolio of effects. With that, I invite you to be doers and to find the bold action. Perhaps what you can do now is find the one partner, the one idea, the one thing you can take away and do in the next 12 months. Please join me in thanking my panel for a wonderful conversation here. Thank you again, everyone.